Okay.
Hi, everybody. I started this meeting and everybody is cameras off, mics off for now. We'll let Dr. Abou Kalil talk a little bit and then I'll take everybody off mute so that we have an opportunity to ask him questions, all right? All right. So thank you everybody for coming and attending today. Today, our C3 chat is about surgery for cholangiocarcinoma, a conversation with a hepatobiliary surgeon. We have today here Dr. Abou Kalil, who completed his medical school and residency at McGill University in Montreal before pursuing fellowship training in hepatobiliary and pancreatic surgery at Seattle's Virginia Mason Medical Center. As a hepatobiliary surgeon, he is primarily interested in the surgical treatment of diseases of the liver, pancreas, and biliary tree, and has a special interest in laparoscopic and minimally invasive techniques. Armed with a master's degree in epidemiology, Dr. Abou Kalil's research focuses on surgical outcomes and the use of big data to address and inform questions related to the care of surgical patients, specifically those undergoing surgery of the liver, pancreas, and biliary tree. So thank you so much for taking the time to speak with us today, Dr. Abou Kalil. I'll pass it over to you. Like I said, Dr. Abou Kalil will go over a few slides and explain a few things, and then we'll open up the floor to questions.
Okay, perfect. I'm gonna just bring up the chat box so that if people have any questions, just put them in the chat box. Sometimes I may not be looking at the chat box too much, so you can also just feel free to interrupt. I think it would probably be useful for everyone to just keep it fairly open, fairly conversational, fairly discursive, and that way probably everyone can kind of get what they want out of it. I do have a little presentation, but the presentation is just kind of sticking to the basics, and obviously there's a lot of nuance. So just try not to take everything that I say to kind of the letter of the law. There's a lot of nuance and just so many factors that go into things, from patient anatomy to tumor specificities to volumetric considerations. There's just so much that goes into surgery for cholangiocarcinoma. It's literally a 2-year fellowship to get to the point where someone can really kind of maneuver through all those really complex decision-making nodes that go into whether surgery is the right thing to do for patients with cholangiocarcinoma or not. So yeah, and sorry, Leonard. Yeah, okay. That's just Leonard saying, yeah, feel free to ask any questions you want in the Q&A or in the chat box. And I'll try to look at that, everyone. And maybe let's just keep it in the Q&A. That way I don't have to look at both things. Okay. All right. Let me share my presentation here. Can everyone see this?
Yeah, I can see it. Yeah.
Perfect. Okay. Okay, excellent. Okay. So the topics that we're going to cover broadly are basically what's the goal of surgery in cholangiocarcinoma, why do we operate on patients with cholangiocarcinoma, what patients with cholangiocarcinoma benefit from surgery, and then what kind of surgery is done generally and broadly to try to treat cholangiocarcinoma. What are the principles of surgery to try to manage this disease in the operating room? The goal of surgery in cholangiocarcinoma is to provide patients with an opportunity for a cure, and or to prolong survival for patients who ultimately may not end up experiencing a cure. The surgery is traditionally thought of as the only chance of a cure for most patients with cholangiocarcinoma. There's a few patients that have been cured in the absence of surgery, but you could probably count these patients on your two hands. And so for the overwhelming majority of patients who have experienced a cure from cholangiocarcinoma, that goes through surgery. The flip side of that value proposition is not always true, in that, of course, surgery does not always guarantee a cure. The reality is that for many patients, they will go through surgery and their cancer may recur down the road. And it can be difficult to predict exactly which ones are the patients who have the highest chance at a cure and who are the patients in whom a cure is unlikely to be obtained from the get-go with surgery. And so we look at a variety of things to try to understand that. We look at stage, and by stage, we mean the extent of spread of the tumor from a stage 1 cancer that is very small, limited to the organ in which it originated, going through stages 2 and 3 that describe varying extents of local invasion and lymph node metastases. So spread to the lymph nodes that drain out that part of the body of the liver. And then to stage 4, which is distant metastases. So either metastases to distant organs, such as the liver, the bones, distant metastases within the same organs, so spread, from the right side of the liver to the extreme left side of the liver, for example, or to a lymph node that is not within the immediate lymph nodal drainage basin of that tumor, a lymph node that is very distant, by the aorta or by the kidney or something like that, where that would be considered a metastases, or, for example, within the lining of the abdominal cavity. We also know that receiving chemotherapy after surgery is associated with improving probability of a cure and certainly improving survival. So on average, patients who are able to receive chemotherapy after their surgery for cholangiocarcinoma experience a survival benefit compared to the patients who either don't get chemotherapy or are unable to get chemotherapy. So generally, who's going to be a candidate for surgery for cholangiocarcinoma? Obviously, there's underlying patient factors and the underlying patient health, in that the patients have to be, well enough to undergo surgery. And they have to be well enough to undergo the surgery of the magnitude that is being proposed. So they have to be able to undergo general anesthesia to come through that, and then to recover meaningfully on the other hand, meaning in a way that preserves their quality of life, and that allows them to go on to the next steps of that journey, which, as we said, for most patients involves chemotherapy after the resection is done. Staging, which we talked about a little bit earlier, is also important to determine who are the patients that will benefit from surgery. Surgery is a form of local treatment. It's a regional treatment modality. And it provides a benefit to patients who have a regional and local disease. For patients who have disease that is already spread at the time of diagnosis, surgery to the primary tumor does not provide a benefit. In fact, it's the opposite. It might provide a disadvantage by distracting away from the therapy that would provide a survival benefit at that junction in time, which would be systemic chemotherapy. So that's why in patients who are diagnosed with a cholangiocarcinoma or a presumed cholangiocarcinoma, the first exercise is the one that we call staging, and that determines the extent of tumor spread. Is the extent of tumor spread within the organ in which it originated, into adjacent organs, into important blood vessels in that area, for example? Is there spread to local lymph nodes, spread to distant lymph nodes, and spread to distant organs, such as the lining of the abdominal cavity, the lungs, the bones, etc. And so before we put a patient on the operating table, we have to be fairly certain that this is a patient that does not have spread. Otherwise, they would not benefit from the surgery. And in fact, the surgery only exposes them to the risks of the surgery without any opportunity for a cure, which, as we said earlier, is the ultimate goal of this surgery. This is a classification that is probably familiar to most of the patients on the call, but when we talk about cholangiocarcinoma, we are talking about different disease sites. The biliary tree can have cancers at any point within that system, in the main trunk, all the way to the main branches, all the way to the little leaflets in the periphery. And depending on where that cancer arises, so what kind of cholangiocarcinoma we're talking about, that surgery ends up looking completely differently. So for example, if we have a cancer that is an intrahepatic cholangiocarcinoma, meaning that it arises above the second order radicals in the tiny little branches of the biliary tree, in the ductules really, then the treatment of that looks like a liver resection. We'll talk about that in a moment. If it's what we call a hilar or a perihilar tumor, historically we would call these Klatskin tumors. These are tumors that arise usually at or close to the bifurcation of the biliary ducts, sometimes a bit more towards the right, sometimes a bit more towards the left. And then that surgery looks like has to address that particular anatomical specificity. And then if it's in the distal part of the common bile duct, especially as it starts to enter the pancreas before it joins up with the duodenum, then that essentially looks like a pancreatic surgery. And the surgery that we do for that is sometimes called a Whipple procedure or a pancreaticoduodenectomy. So we can see that depending on where in the biliary system that cholangiocarcinoma is arising, that surgery can look completely different. The risks of the surgery are completely different. The special considerations and what we have to look out for could be completely different. And the one that we haven't talked about that's not here on this graph is gallbladder cancer. So the gallbladder is an extension of the biliary system, and gallbladder cancer is a form of a bile duct cancer, is a form of cholangiocarcinoma. And that surgery ends up looking very different as well. It has its own specificities. So different surgeries for different locations. And maybe we'll spend some time talking about each one of these in a little bit of detail, but not so much detail that it will bore you, just to illustrate a little bit the complexities of each one of these sites and the kind of pain points that end up limiting resectability and limiting the surgical options for many of these patients. So we said when we're talking about an intrahepatic cholangiocarcinoma, we're talking about a cancer that is nested within the liver substance, within the parenchyma of the liver. And so to remove that tumor, you have to remove the part of the liver that tumor is in. And often we end up sampling the lymph nodes that are in the stalk of the liver, in this kind of area here. So for example, if you have a cholangiocarcinoma in segment 2, you could just remove segment 2 and then go and strip the lymph nodes there to complete the staging. The goal of removing the lymph nodes is to basically just understand a little bit more about the biology of the disease and to understand whether this is a cancer that has spread to the lymph nodes or not. Removing the lymph nodes doesn't inform the treatment in any way, meaning that chemotherapy is recommended for patients who have lymph node metastases and those who don't have lymph node metastases. They both appear to benefit somewhat from chemotherapy. It doesn't inform how we surveil patients, meaning that the protocols of surveillance and how often and for how long we follow patients after surgery doesn't change whether they have lymph node metastases or not. And so sometimes the lymph node stripping will be foregone, especially if it causes extra complications or will prolong the surgery significantly, or there's other local factors that will prevent that from happening. Sometimes that will be foregone. It doesn't provide any survival benefit in particular to remove the lymph nodes there. Really, the survival benefit comes from removing the tumor itself. If you have a tumor on the right side of the liver, for example, then you have to remove that right side of the liver, especially if you cannot do a more limited resection. And so, just like for all the cholangiocarcinomas, the first step is you make sure that there's no spread of the cancer. And if there isn't any spread of the cancer within the limitations of and the detection limit of the imaging modalities that you have, that may be CT scans, MRIs, etc., then you would be inclined to proceed. often surgeons may choose to do something called a diagnostic laparoscopy to make sure that there isn't carcinomatosis or spread within the lining of the abdominal cavity. That pattern of spread can be very difficult to see on a CT scan and may often be found at the time of the surgery. So sometimes that diagnostic laparoscopy can be done either at the same time of the surgery or sometimes at a separate sitting, just to reassure ourselves that we've really made sure that there isn't any evidence of spread before we go ahead. Therefore, one of the important considerations in talking about liver surgery is, can you design a surgery that leaves the patient with enough liver volume behind and spares the inflow and the outflow vessels to that remnant? Typically, we want at least 25 to 30% of normal, healthy liver volume left behind. And the liver is a miraculous organ. It can grow back, it can regenerate, but you have to leave enough of it behind, and it has to be healthy enough to grow back and regenerate. And so for many patients, if removing the tumor means that they have less than 20% of their liver left behind, you cannot proceed because we cannot live without our liver. There's no medication or technology that can replace the functioning of the liver today in 2025 that is commonly available. If you have kidney failure, you can be on dialysis for the rest of your life. There's nothing similar for the liver. So if you go into liver failure postoperatively, and that's not just a transient liver failure that rapidly improves, that's a life-threatening situation to be in. So as surgeons, we are very careful about making sure that before we commit a patient to a major liver surgery, that we're fairly certain that they have enough liver remnant behind and that the liver remnant can grow and can regenerate and is healthy enough. So we have some tricks up our sleeves sometimes if that surgery cannot be designed while leaving 25 to 30% of the liver behind. Sometimes we can force the growth of the liver remnant, or try to force the growth of the liver remnant, by choking off the blood supply to the side of the liver that we're going to be removing. That redirects the blood flow to the side of the liver that will stay. And if we see enough growth that will reassure us that we're going to be out of the woods, so to speak, in terms of liver function perspective, then we would go ahead with the liver surgery at that point. So there's a few hoops that we'd have to jump through at that point to get the patients to a point where they can have a liver surgery when their liver volumes otherwise would not allow it. We also look at things intraoperatively, as we said. Whenever we start that liver surgery, we're going to go back to verify all those assumptions that we made preoperatively. Make sure there's no evidence of spread. Make sure that the remnant liver looks healthy enough to undergo that liver surgery. We look at a history of cirrhosis, fatty liver disease, PSC, to try to understand, again, well, what's the health of the underlying liver? Can that patient survive just based on that remnant? And sometimes that will end up limiting the option for surgery. And we can talk about other non-surgical options at that point. For a minority of patients, these are going to be things like considering transplantation, although there's a lot of hoops that we'll have to jump through to get there. And so that won't be so much the subject of the talk today, the kind of transplantation for cholangiocarcinoma. We'll mostly be talking about resectional surgery today. So that's for intrahepatic cholangiocarcinoma, so cancers that are nested within the substance of the liver itself. For hilar cholangiocarcinomas that are involving the bifurcation of the biliary system, here we're not just talking about a liver resection, we're also talking about removing the main biliary bifurcation, the bile duct, the common bile duct, the main trunk that collects all the bile from the liver and gets it down to the intestine and the pancreas, and then reconstructing the intestines to the bile ducts directly in the liver at the cut surface that's left behind. So that's hepatectomy, bile duct resection, and then a bile duct reconstruction. And typically the bile ducts are reconstructed to a loop of intestine that is brought up and sutured to the bile duct as it's coming out of that cut surface of the liver. Again, here determining what are the patients in whom that surgery is going to be feasible. We look at, again, ruling out any metastases, ruling out any spread. Once we're satisfied that we've ruled out spread to the best of our ability and within the limitations of these modalities. Then we try to ascertain, again, to the best of our ability to do so, what is the extent of this cancer along the biliary system? How far is it spreading? And that can be extremely difficult to ascertain. There isn't a single imaging modality that will definitively tell you exactly where the cancer stops and where the cancer starts and where it ends. You're trying to piece together that information from MRCP, ERCP, CT scan, impact on surrounding structures, etc. The goal of the surgery is to get to a point where you've cleared the tumor, but where you also have microscopically negative margins. Because it's one thing to cut out the tumor that you can see with your eyes and feel with your hands. But if that tumor is extending microscopic tumor cells beyond that, well, you can't see that in the operating room. And you can't see that on a CT scan or anything like that. Then there's a certain risk of leaving cancer behind at the cut surface. Often what the surgeons will do in the operating room is once they've cut to the extent of where they think the tumor ends, they will send what's called a frozen section. And the pathologist will look at that margin, at the cut surface right there and then, and say, okay, there is tumor cells at the cut surface or there isn't. And if there's cut surface if there are tumor cells at the cut surface, then if you can chase that more and take more of the liver and take more of the ballast, then you can chase that. But oftentimes you can't. You've taken as much liver as you can. And if the margin is still positive there, you don't always have the ability to chase that back to a negative point. So this is kind of one of those situations here when you have a bismuth-4, that tumor is infiltrating towards the second order radicals, and you cannot design a surgery that will cut back to normal bile duct and leave enough liver behind, and that often ends up limiting things. Again, here we're talking about volumetric considerations of how much liver volume are you leaving behind. And because these are cancers that are often arising in the hilum of the liver, in the stalk of the liver, through which all the blood vessels are running, the portal vein that's bringing blood from the gut up to the liver, and the hepatic artery that is bringing blood from the aorta up to the liver, everything is in very close proximity here. If the tumor involves the main blood vessels, then it is unresectable. You cannot reconstruct that there. Some of those vessels can be reconstructable sometimes, but usually when the artery is involved, we consider that unresectable. If it's a minor part of the portal vein that is reconstructable, you can sometimes reconstruct that, again, depending on the local anatomy, the specificity of that tumor anatomy. And again, there we have to be concerned about the health of the underlying liver and the health of the underlying bile ducts as well. Is there PSC in the remaining bile ducts, for example, that would complicate your ability to suture and reconstruct to those vessels? And often surgery is not going to be a good option in these situations. Another thing that differs when we talk about a hilar cholangiocarcinoma and more distal cholangiocarcinomas in the main bile duct into the pancreas, compared, for example, to an intrahepatic cholangiocarcinoma that's nested far up into the small bile ducts in the substance of the liver, is that these patients often have jaundice as their clinical presentation. And so then you have to deal with the jaundice as well. And that may involve endoscopic treatments or percutaneous treatments to put drains. And so that's another kind of layer of complexity that is added in the management of patients with a hilar cholangiocarcinoma that isn't there when we're talking about, by and large, isn't there when we're talking about an intrahepatic cholangiocarcinoma. Gallbladder cancer is another one of those areas of specificity where the treatment of the gallbladder cancer typically involves removal of not just the gallbladder, but the gallbladder with the part of the liver that the gallbladder rests upon. we'll often look at the cystic duct margin and make sure there's no cancer there. And if there is cancer there, you'll have to chase that, sometimes down to the main bile duct and to reconstruct the main bile duct. And we do strip the lymph nodes as well for the same reasons that we do for an intrahepatic cholangiocarcinoma or a hilar cholangiocarcinoma. Um, uh, to give us a bit more information about the biology, complete the staging, and give us an idea about what the risk of recurrence is and what the probability of a cure actually is. And then I don't have a slide for this one, but we can talk about what happens when the cancer is in the distalmost part of the bile duct as it enters the pancreas and joins up with the duodenum. And to remove these kinds of cancers, we very much treat them the way that we would treat a pancreas cancer in the head of the pancreas. We often have to control the jaundice before the surgery, as these are tumors that often will present with jaundice as they're presenting symptoms. And then to treat them, we would have to remove the head of the pancreas along with the bile duct and the duodenum and the gallbladder, because these organs are all very intimately associated with one another. We strip the lymph nodes from that area as well. And then we have to reconstruct everything together. We reconnect the intestine to the pancreas. We connect the intestine to the part of the bile duct that's left behind. And then we connect the intestine to the stomach or the part of the stomach that's left behind. Sometimes you can spare the stomach, sometimes you can't. And so that's a different set of operative risks, considerations, potential complications are totally different from what a liver resection would look like, for example. Many of the complications of these surgeries are related to the pancreas rather than anything to do with the bile ducts. That's kind of it. That's the broad overview of principles of surgery for intrahepatic, hilar perihilar, distal cholangios, and gallbladder cancers. And so I kind of kept it very kind of broad. And perhaps now what we can do is we can see what kind of patient questions we have and see if we can address any of the questions that the patients have and maybe address what they themselves want to know a bit more about. So let me see here.
Excuse me. So I've given everybody the ability to unmute yourselves and to turn on your video if you'd like to ask Dr. Abou Kalil any questions. Thank you, by the way, Dr. Abou Kalil, for going over everything. I actually never realized that you can consider gallbladder a type of cholangiocarcinoma. I always thought it was kind of its own thing. I know that it's part of the biliary tract, but I like that. I like thinking of it.
It is. In fact, it's often included in clinical trials for cholangiocarcinoma. So, for example, the trial that demonstrated a survival benefit to adjuvant chemotherapy, so chemotherapy after surgery in patients with bile duct cancers, included patients with gallbladder cancer. And again, all these cancers can be quite different in their genetic underpinnings, in their risk factors, in the demographics in whom they typically present. But they are all cancers that arise within the same system and within the same biliary epithelium.
Margaret, do you have a question?
I actually do have gallbladder cancer. That is my primary, is the gallbladder. So I find this really interesting. But I know that they did, as many biopsies as they could, but they're still not exactly pinpoint sure whether it started in the duct or whether it started in the liver. Like they can't see because they say the stones got in the way.
Yes.
So it's very difficult for them to pinpoint because they can't view even with the scope that they had done. Like they had done a scope that you know, I don't understand all of it. I'm just a patient. But they had shown a light and a scope through my stomach in order to be able to view the gallbladder better endoscopically. And they could not view what they wanted with those stones in the way. So I'd love to be able to see a slide, you know, of what that kind of looks like, but you
Yes.
don't have
Okay.
one.
So probably what you're describing is an endoscopic ultrasound,
Yes.
where they would go down with a gastroscope that has a little ultrasound probe that's mounted on top of it, and they can kind of do an ultrasound from the inside, essentially. And sometimes they can take biopsies through that if they see something that they can safely and clearly access. Um,
Not in my case.
yeah. Did they ever get tissue?
They had to use the tissue from the liver, and somehow that gave them the information from going into the liver to get the primary of gallbladder. But I don't know if that's, I don't know how that works.
Yeah, and sometimes it is a clinical diagnosis. You know, it's you have a mass that's arising in or close to the gallbladder. And sure, did it arise from a small bile duct close to the gallbladder? So it's an intrahepatic cholangiocarcinoma that's just in the exact vicinity of the gallbladder, or did it arise in the gallbladder and invaded into the liver? Sometimes it's very important to answer that question, and sometimes it's not important to answer that question. You know, it's more like an academic point. And some of the other principles of surgery take over. You know, is there distant spread? Is it resectable? What's the health of the underlying liver? What's the staging? What does that surgery look like? Is it feasible? All those other considerations kind of take over, and exactly what the origin of it was uh, is not always very important to answer.
May I ask another question, please?
Of course.
They had said that maybe the stones themselves might have kind of, I don't know, stimulated the
That's a
growth
good
of the
question.
cancer?
So we can talk about what the risk factors for gallbladder cancer are, and gallstones are one of the risk factors for gallbladder cancer. It should be said it's not the stones themselves, it's what the stones cause in the underlying gallbladder in terms of chronic inflammation. So chronic inflammation of the biliary tree in general is what predisposes patients to cancer. There's a relationship between cancer and inflammation there. And so you know, chronic cholecystitis from gallstones, for example, does increase the risk of gallbladder cancer. So that's why there is a relationship there. Yeah.
Thank you.
Yeah. There are other risk factors for gallbladder cancer as well. In certain populations, there's a very high frequency of gallbladder cancer. We're thinking about the Andean highlands, some parts of Southeast Asia, and this has to do with the kind of bacteria that can colonize the biliary tree in these populations. But often it also has to do with the fact that these populations have a very high incidence of gallstones, presenting at very young ages across the population. And so high incidence of complex gallstone disease with a lot of chronic cholecystitis. And so in these populations, you do experience a higher populational incidence of gallbladder cancer. In North America, gallbladder cancer is rare. But there are parts of the world where gallbladder cancer is a little bit more endemic and unfortunately not so uncommon. And that's got to do with, in some populations at least, high incidence of very, very high incidence of gallstone disease.
I could ask you a million questions. So please, anybody else, if you are interested, you can either raise your hand, come off of mute. But I will just ask you, Dr. Abou Kalil, So Leonard put one in here, which is good, which is what is the general post-op care that's associated with these types of surgeries, and how extensive is the recovery process?
Sorry, I can't see. Is it
Leonard asked
yeah,
that question, yeah.
So Leonard, it really depends. It really depends. So as I try to illustrate, there's a huge spectrum of what these surgeries look like. Some of these surgeries are actually fairly minor surgery. I just talked to a patient very recently, and will be operating on this patient very recently, who is going to have essentially a day surgery, because we do a lot of these surgeries robotically right now. And if you can have your surgery robotically, and if it's a surgery of a certain extent, then typically, you could go home on the same day or possibly the next day. And depending on what line of work you're in, you could be at work within 10 days, 2 weeks. If it's a bit more physical job, then it's a little bit more than that. So you can have a fairly swift convalescent experience if that's what needs to happen for you. You can have, for example, a small lesion that requires the resection of 2 or 3 liver sections and the lymph nodes, and it can be done in a robotic or in a laparoscopic fashion, and you're healthy. There's no reason to keep you in the hospital from a medical or anesthesia perspective. Then you'll get the surgery, go home on the same day or maybe the next day, and the recovery can be quite swift, and you can be talking about chemotherapy in the next month or so. And then there's patients who have to have a major surgical adventure, and many of those cannot be done in a minimally invasive fashion. Sometimes you can do the hilar cholangiocarcinomas in a robotic or minimally invasive fashion, but oftentimes, especially when there's so many decision-making nodes in the operating room, you have to clear the artery, clear the vein, clear the duct, make sure the margin is okay on the duct, send the margin, revise the margin, etc. It's hard to do all that robotically or laparoscopically. The risk of liver failure is much higher. The risk of a leak from the connection between the intestine and the bile duct is much higher. And this is a much longer convalescent experience. Most patients will be in the hospital, anywhere between 5 days to 12 days. The risk of complications is higher with these kinds of procedures. If we're talking about a Whipple procedure, for example, whether you do that robotically or open doesn't really change the major risks of that surgery. And about 30 to 40% of patients undergoing a Whipple procedure, for example, will experience a complication of some sort. Sometimes it's something simple, like a wound infection that is just opened and treated. For many patients, it'll be a leak from the pancreas itself, and that will be managed with drains and antibiotics for a few weeks until the situation gets under control and we can remove the drains. So yeah, just a very, very wide spectrum of biological behavior. Question from Christine. Sorry, maybe I ignored that. Why are people with liver mets eligible for liver surgery? Sorry, why are people with liver metastases eligible for liver surgery when cholangiocarcinoma patients are automatically ineligible if they're spread? Okay, I think Christine, what you're implying is, so there are other disease sites, other metastatic cancers for which we do entertain liver surgery to remove metastases.
Yeah.
But typically for cholangiocarcinoma, we don't entertain that. And the most common site is colon cancer. So when patients have colon cancer that metastasizes to the liver, we do, even though they are stage 4, technically, we do actually try to design surgeries that clear the liver of the metastases. And the reason for that is that we know that prolongs survival in this patient population. And that's because there's been lots of trials, including randomized trials, that have clearly demonstrated a survival benefit in these patients. It should be said, even in that context, most patients are still not going to be cured, but there is a certain non-negligible proportion of patients who will be cured from the colon cancer liver metastases removal from the liver. And so we give patients the benefit of the doubt. When they recur, we go back to the drawing board, and we can see that extends patients' lives, even those who aren't eventually cured would have lived longer than had we not done the metastatectomy. And that's not the case for cholangiocarcinoma, by and large. Are there, kind of exceptional patients who've had oligometastatic disease or oligometastatic recurrence who, after prolonged periods of stability, we do consider sometimes doing something local regionally? Sometimes. But I would say that's very much the exception and is not typically entertained without extensive multidisciplinary involvement and without significant demonstration of disease stability, and after a lot of consideration and really looking at the nitty-gritty of each case. But by and large, there's no benefit of patients of cherry-picking metastases. And the idea there is that when you see a metastases, you worry that that's actually just the tip of the iceberg. If there is one, there's more. And so focusing in on that single metastases distracts away from what that patient really needs, which is a treatment that not only treats what you can see on a CT scan, but what you presumably can't see but is there. And that's chemotherapy, immunotherapy, other forms of systemic therapy that treats what you can see and what you can't see. Barry, sorry, I'm just going to pull up the Q&A here.
It might be Barry. It might be Margot, who is Barry's wife. Are the chances
okay.
of survival after resection similar in the different subtypes of cholangiocarcinoma?
It's very much stage dependent. So I guess you could say apples to apples, yes. But for example, it's much harder to get a margin negative resection for a hilar cholangiocarcinoma than it is for an intrahepatic cholangiocarcinoma. So there's a lot of considerations that go into that. So you could say, apples to apples, like a T1B N0 intrahepatic cholangiocarcinoma, grade 1, same differentiation characteristics, same lymphovascular invasion, same. Yes, probably that the survivals do approximate each other. The problem is that we're using these categories to categorize or put in boxes diseases that are actually quite heterogeneous still underneath that, right? Meaning that today in 2025, all we can see is, okay, under the microscope, what's the grade? What's the differentiation? Is there lymphovascular invasion? What's the margin? But actually, the complexity of what's going on underneath that is something that we are only now starting to understand, in part thanks to the efforts of C3 and other collaboratives that are trying to help us understand the genetic underpinnings of that. So, is a T1B hilar cholangiocarcinoma compared to a T1B intrahepatic cholangiocarcinoma, but one has a P53 and a KRAS mutation, and the other one has an ERB4 mutation. So they're not actually the same. So what are all the nuances and all the complexities that are there? No, I don't know. We don't know that. It's almost more of an academic question because it doesn't actually inform patient care. Like you're never going to not offer a patient a resection just because it may have been a bit worse had it been a hilar, or would have been a bit better had it been a hilar or not. Certainly some of the anatomical complexities that prevent us going ahead with surgery are not the same for all across disease sites. So an hilar cholangiocarcinomas that arise at that bifurcation of the bile ducts, there's so many decision-making nodes there. Is there arterial involvement? Is there portal vein involvement? What's the extent along the biliary system? And can I reasonably think that I can clear this margin based on what I can see? Is there enough volume to allow for that? Is the underlying health of the liver going to allow for that extent of resection? Just so many decision-making nodes that the likelihood that you're going to jump through all these hoops becomes less and less if you have a hilar cholangiocarcinoma than if you have, for example, an intrahepatic cholangiocarcinoma stage for stage. So
I have another question for you.
Oh, sorry. Just before that, I think Mr. Pham maybe was trying to ask a question.
Oh, go ahead then.
Yeah. Actually, I would like to ask on behalf of my husband. Origin, he had 2.2 centimeter of tumor and at the bile duct. And after 6 months of chemotherapy, and it's shrink to 1.7. 0.7. Yeah. 0.7 centimeter. And origin, they had only ERCP, and besides that, he didn't have the liver biopsy. But because of when the doctor referred him, for the surgery, and the specialist told him, I assume if your liver has a cancer spread, you are at stage 4. But actually he didn't have a liver cancer test yet. So we don't know whether when the tumor shrink already, so will he have, an operation for that? Because now he had 6 month chemotherapy, and now the doctor said, oh, the tumor shrunk. So I put you on the, immunotherapy once a month.
Mm-hmm.
And
Yeah.
the question whether he need a surgery, or he wonder what stage is he to, because when he had the liver CT scan, and the doctor said your liver is clear, so we really wondering whether he is at stage 1 with 2.2 centimeter at the origin, or he is stage 4.
So if I'm understanding correctly, did he have liver metastases on the first CT scan and then they disappeared with the chemotherapy?
They saw some of the dot on the liver, but now they don't see it anymore.
Right. It's responded to chemotherapy. So that's a good question. Again, not to speak too much to the specificity of your own case, but sticking to kind of the general principles of things. When someone has metastases at the time of the diagnosis, we consider that stage 4, as you correctly pointed out, Mrs. Pham. If you get treatment and things get better, you're still stage 4, meaning that you have a cancer that was spread at the time of the diagnosis. And so we don't downstage that back to stage 2 or 1. Once it's a stage 4, it's just a stage 4. And those metastases are there. It's always encouraging when we see a response, because it means, we're doing well and we're having the impact that we're hoping we have. But if, for example, if you deemed someone unresectable because you had convincing evidence that they had metastases at the onset, the fact that they've responded and that, for example, you're no longer seeing these metastases doesn't make you resectable at that point. You don't go back to the drawing board from that point of view. The second point I think I'd like to make is about the size. So obviously, as patients, we always scrutinize the size. It's one of the things that we can kind of put our hands on, and we put our hands on it because it kind of tells us, okay, well, how bad is the situation? Is it 2.5 centimeters? It's just this concrete thing that patients like to hang on to at a time of uncertainty and where everything seems so abstract. Like the size is something that we often hang our hat on. But the reality is that as surgeons, we rarely scrutinize the size. I wouldn't say it's not important, but it's probably not the most important thing. And what matters often, especially for a hilar cholangiocarcinoma, is all about location and relationships. The location of the tumor and its relationships to the surrounding blood vessels that determines the resectability. And size has something to do with that. Obviously, if you have a huge tumor, the likelihood that it's involving some of these critical blood vessels is higher. But often you can have a very small tumor that is just in a very bad place and that has all the wrong relationships, and the size doesn't matter as much. So is there situations where you give chemotherapy to decrease the size, but really to pull it away for some of those blood vessels to open up an avenue for surgery? So that is often the goal of what we call neoadjuvant chemotherapy. You give chemotherapy in the hopes that it will open up an avenue for eventual surgery. And so, the details of that you would have to discuss obviously with your treating team to understand, was there truly metastatic disease before, or was it something that was kind of questionable and they weren't abscesses or anything like that, or something benign? And if not, then have those relationships that made the tumor unresectable, aside from that, have those relationships improved in a way that would open up an avenue for the possibility of a curative surgery potentially.
Can I have a question? Yeah, Thai
Yes,
farm.
of course.
Yeah, from originals, my tumor is a 2.1 centimeter, and after 6 months, and now it's shrink just 0.7. That means 1/3 compared with before. And by the time they suspicious, I get threat to liver. But the day they schedule me to do a biopsy for my liver, I have to another appointment for scan for the bile duct. So I have to cancel the biopsy for liver. And till now I don't know. I'm not exactly, I know I got threat to liver or not. But the CT scan just happened ago, and they said that my liver is clear. I don't know. And now they said that they let me do like a immunotherapy and no longer chemotherapy. And one thing, from beginning till now, I never had a pain on my right side abdomen, stomach. People get liver cancer used to, get a pain on the right side, right? But I never got a pain on right side. That even the doctor, they understand too. So I wonder what I will do next,
Yeah, I would say, I think that's maybe a bit of a misconception. So most patients with cholangiocarcinoma or liver cancers don't have any pain. The liver is generally insensate. The liver itself does not feel pain. Sometimes you can have some pain from stretch of the liver capsule, or if there's a process in the liver that's affecting the abdominal wall, that's when you start to perceive pain in that location. If there's gallstones or something like that, then you can have pain from that. But by and large, these are painless pathologies, which is why they can sometimes present quite late. So that's a good point, Mr. Pham. But just because there's no pain doesn't mean anything from a clinical perspective.
Thank you.
Thank you, sir.
You're welcome, Mr. Pham.
If there are no more questions from the audience, I do have one last question I wanted to ask you. And it's about this idea of second opinions, because in the States, the medical system is so different, and people are very much encouraged to seek out second opinions. And, obviously, like, you have extensive training specifically for hepatobiliary surgeries. And like, depending on where you're located, you may or may not have as much access to a team that just has more experience in these particular surgeries. What is your experience within the Canadian setting with that idea of going and asking for a second opinion specifically for surgery? And like, how do you, like, as physicians, kind of come to the conclusions that you do for each individual patient?
Yeah, that's a very good question. So you're right to say that the landscape of care in the US and Canada is quite different. So in Canada, by the time that you're meeting with a hepatobiliary surgeon, a hepatobiliary and pancreatic surgeon, you're meeting with someone who's been like vetted quite extensively, I would say. To get those academic jobs in Canada, there's a lot of hoops that you have to jump through. And because healthcare is quite centralized, especially cancer care being so centralized, the only people that do these kinds of surgeries are people who are qualified to do them and have that volume concentration. So that's essentially all that I do. All that I do is liver, pancreas, and bile duct. I cover a little bit of call for acute care, for emergencies, but that's all we do. And we work in a group practice here. There's 5 of us, and that's all that the 5 of us do: biliary, liver, and pancreas. In the United States, the landscape of care can be quite a bit more heterogeneous, in the sense that you may end up seeing someone who actually is dabbling a little bit. There's some dabbling in the United States, in the way that here, no one will let you dabble in that. It would just, you would never get that consultation, would never be sent to you. And the minute that if it does end up in the wrong hands, it will immediately get channeled back to the person who has the highest volume for these kinds of things. The community of HPV surgeons in Canada is also quite small. We all know each other. We're all friends with each other. So we all know, when someone is doing something a bit different, or someone has a clinical trial that, is not available at your site, but might benefit a particular patient somewhere, then we're very quick to refer these patients out. So, for example, the patients that we refer the most are the patients who are going to be not a candidate for surgery, but are going to be a candidate for transplantation. Because, for example, we don't have a transplantation program here in Ottawa, and in the province of Ontario, you can only get transplanted for cholangiocarcinoma at a single site, which is Toronto General. So care is just so centralized that if that's what we think you need, you end up being seen there. The reality is that in many Canadian programs, because all of the cholangiocarcinoma cases are presented at what's called a multidisciplinary tumor board, this is where, myself, my colleagues, we get together with radiologists, oncologists, radiation oncologists, pathologists, nuclear medicine specialists, everyone that has anything to do with the treatment of these patients will all get together, and these cases all get presented, and you get basically multiple opinions. You kind of get a second, third, fourth, and fifth opinion when they're being presented at tumor boards as well. And we do have patients who want to seek out a second opinion as well somewhere else before they commit to a particular treatment avenue. And we're happy to reach out to, again, the community of HPV surgeons is very small, and have them be evaluated somewhere else as well for just a second opinion, just to see and make sure that there aren't any other ideas that would be entertained. I will say, of all we've sent a few patients over the years to second opinions, and the second opinion has always been the same as the first opinion. Sometimes resectability is in the eye of the beholder, especially when it's got to do with the nuances of what you're seeing on the CT scan, where you think the disease is, how high the tumor markers are. And so, yes, sometimes there can be slightly differing opinions. But by and large, those opinions are the same. And by and large, when we do send patients out, it's to see if they wouldn't be candidates for something that is not available locally, like a liver transplantation.
Yeah, and as I mentioned in your intro, you did train in the States, so it's not like a lot of Canadian doctors do end up doing some part of their training often in the States. So
I would say most, many, if not most, have trained elsewhere. The kinds of surgeries that are available, I mean, you can get the same surgery here, there, everywhere, robotically, open. Those end up being a little bit, details, really. There's rarely a kind of surgery that is available somewhere else that isn't available here. Probably the only thing that is maybe a bit more readily available elsewhere is a robotic hilar resection. There's only one center in the US that does them. But again, the risks of that surgery are the same, whether it's done in an open or robotic way. So that's why we try to avoid doing that, really.
well, thank you so much. We've come to the end of our time. So again, thank you so much, Dr. Abou Kalil, for taking the time to speak with us. If there are any follow-up questions, please just email them to me, and I will arrange to see if Dr. Abou Kalil can answer them. Otherwise, next month we are going to be talking with Dr. Amandeep Tagar, who is a radiation oncologist at Sunnybrook in Toronto, and he's going to be talking about local regional therapies involving radiation and the like. So take care, everybody.
Thank you, everyone.
Thanks, Christine.
Thank you, doctor.